right, welcome everyone to the Barlow Brain and Body Institute, and tonight we're going to be talking about frontal lobe function. So a couple of things that we need to know right up front is this is the side view of the brain, and then what separates the brain is we have the central sulcus and the Cerebellar fissure. So the central sulcus actually separates this posterior part of our brain, which is all sensory. That's important, all sensory. And then in front of this central sulcus, this is our frontal lobe. All right. So now we need to understand the homuncular mouth, because the primary motor cortex, which is in the frontal lobe, all right, primary motor cortex here, all right, area 4. And then back here in our parietal lobe, area 3, 1, and 2, both of these together have what is called a homuncular mouth. The reason that's important is we need to understand that on this lateral side of our brain, frontal lobe and parietal lobe included, we have a homuncular mouth, and on this lateral side, this is controlled by the blood flow in our middle cerebral artery. The middle cerebral artery, if you look at the homuncular mouth, is going to control the contralateral face and hands. Now, when the brain comes together, right brain, left brain, we have a parasagittal space, this little valley in here. And in that valley, we have a river. And that river that runs through it is called the anterior cerebral artery. So the anterior cerebral artery, we look at the homuncular mouth as we start to come over the top into this parasagittal space. We have our low back, hip, knee, foot, and genitalia. So we need to understand that, and that's controlled by the anterior cerebral artery. So when we do a temperature gauge, okay, and it's the one that you've probably seen before, you can pick it up at Lowe's. It's going to get the surface temperature, not the actual body temperature, but the surface temperature, which usually runs somewhere between 89 and 92 degrees here. Okay, so we'll just use the number 90 as the surface temperature. Now, when we test the hands, there should be no more than 2 degrees difference between the surface temperature in our hands and surface temperature in our feet. The reason this is important is because when we have cold hands and cold feet, what this is going to mean is we're not actually shunning blood flow through the middle cerebral artery, lateral side of the brain, and the anterior cerebral artery through the parasagittal space. Thus, we have cold hands, cold feet, cold brain. Now, we do need to understand that everything from the right side of the body is going to fire to the contralateral frontal lobe. All right, now one of the things that does stay ipsilateral in the body is our autonomic nervous system. I'm not going to get into detail with that, but just realize that our autonomic nervous system to the vagus nerve is going to fire ipsilateral, and all the motor function is going to fire in contralateral to the frontal lobe. So let's get going on how do we actually test this, because it's going to be difficult to actually know how to treat something, which is the next module, if you don't know how to test for it. So I'm going to use a lady that came in yesterday. All right, so we have our frontal lobe. Okay, ipsilateral to the frontal lobe is our basal ganglion. Then we have our thalamus. I'll just put a T here. This is going to be our midline right here. Okay, midline, and then contralateral to that is we have our cerebellum. Okay, so this is how we're actually going to, or one of the best ways to test the frontal lobe is how well is our cerebellum functioning? How well is our basal ganglion functioning? And one thing that's sometimes overlooked is actually our parietal lobe as well, because our parietal lobe, let's say on this left side here, our parietal lobe is actually presynaptic to the frontal lobe. It means that it fires to it and it keeps it alive. And so remember that there's really 4 things that keep the nervous system functioning at its peak level. Number 1, we've got to have oxygen. Number 2, we have to have a fuel source called glucose. Number 3, we have to stimulate the neurological pathways. And number 4, we've got to maintain our inflammation and keep it under control. So when it comes to stimulation, what stimulates the frontal lobe? Well, a lot of things stimulate it, but one thing that we have a direct impact on is actually doing testing the frontal lobe through light touch, vibration, 2-point discrimination, because if it's altered on this right side of our body through light touch, vibration, 2-point discrimination, our parietal lobe on this left side, remember right side of the body, fires to the left brain, And the parietal lobe is presynaptic to the frontal lobe. So we can't activate brain-derived neurotrophic factors. The stimulation part of the big four is going to be altered. So let's don't forget that. So when we look at this, also the cerebellum, okay, that let's switch gears for just a second, because I was talking about the left brain and I've written everything up here for the right brain. So let's just switch gears for just a second. So everything that's on our left side of the body, our face, hands, and feet, this will fire to our left. Our frontal lobe is going to control all of that function. Sensory input, somatosensory input from our face, hands, and feet will fire to the left parietal lobe. Our left parietal lobe is presynaptic to the frontal lobe, so that's going to keep it alive. So when people are coming in with numbness and tingling and pins and needles in their lower extremities or upper extremities, it's not just affecting the nerve, it's not just affecting the parietal lobe, but also the parietal lobe is presynaptic to the frontal lobe, which we're going to see some compromise in the frontal lobe if this is in early stages or even late stages of frontal lobe decreased frequency of firing. So we know that the cerebellum, how do we test the cerebellum, is EABC. This is eye movements, accuracy, balance, and coordination. All right, so how are we going to test this? Yesterday, when one of my patients came in, she had a car wreck in 1994, and through this cascade of events, she comes in now, today in 2023, on a walker. She can actually, she has difficulty getting words out of her mouth, and she's on this side of her hand here. When she actually starts to do the digit span, she starts to go into a tremor, and her left leg goes into a tremor as well. So if a patient came into your clinic doing that, what in the world would you actually do for this patient? How would you change this person's life? So we look at the eye movements, which is a cerebellar function, presynaptic to the contralateral brain, and we look at these horizontal eye movements. Okay, she can't track the pen, and it was worse when we go down bilaterally. So see, her posterior canals are worse than all the other canals. I ask her when she looks up or leans back, does she get dizzy? And the answer is yes. So I'm going to pose a question to you. This is a frontal lobe seminar, but yet posterior canals of the cerebellum are presynaptic to the cerebellum, and the cerebellum is presynaptic to the frontal lobe. So see, these are treatments that we're going to have to do. So in neurology, we find what they can't do, and that's part of the rehab. Okay, so accuracy. Okay, so when this patient came in, she had, I told her to put her finger on her nose, and she's very, very slow, and she's right here in this shoulder. She's got this kind of drop. Okay, you do this side, it's fine, but we get this kind of drop, this accuracy, and almost like a twitch, or if you will, it's not a tic, but it's an abnormal movement disorder. Okay, so that is off. Her balance, well, her balance is off because she's on a 4-prong walker. I mean, let's get for real. I'm not going to have somebody stand up, put their feet together, and close their eyes and put their hands on their hips and say you should be able to do that for 15 seconds when she's already on a walker. And accuracy, okay? So again, like this lady, when she came in, see how her coordination is off, and then her accuracy, she couldn't find her nose on this right hand. So see, just doing that cerebellar test, doing those 3 movements, we know that for her, again, this is the right cerebellum with this patient because she actually had a left brain problem, Broca's area, and basal ganglia on this left side. So we tested all of these. Okay, with her sensory input was off only in her feet. Her reflexes were fine, which actually kind of shocked me, but that's why we do the exam. So the cerebellum on this side, the cerebellum is contralateral to the frontal lobe. All right. Now, what happens with the frontal lobe, and just a bit, trust me when I tell you this, I'm hitting this not at 30,000 feet, but at 60,000 feet. I give an entire seminar just on the basal ganglia. So just please understand, I'm going to be covering in about 2 minutes what I go into detail in a 16-hour seminar. So the frontal lobe is going to fire down to the basal ganglion. The basal ganglion has a direct pathway, or D1, and an indirect pathway called D2. Okay, so this direct pathway, what it does is it's like a gas pedal in the car. You push it down and you go. The indirect pathway, it's the brake pedal, and when you hit it, you slow down and then stop. Okay, so that's the indirect pathway. So it's real simple. It's indirect pathway, indirect inhibits, and the direct pathway, okay, drives it. So gas pedal, direct pathway, indirect pathway inhibits. Now, so what happens when these systems start to fail, they do right the opposite of what they're designed to do. That should make sense. So when systems start to fail, they do right the opposite. So your direct pathway, which is supposed to give something oomph, all right, and then when it fails, it's like barely can move. Okay, so and the indirect pathway, which inhibits, think of it like we're at a stop sign, and our foot slips off the brake, and then now the car moves forward. So see, again, the indirect pathway is designed to inhibit movement, but whenever it fails, it excites movement. All right, you start moving in ways you're not supposed to move. So this basal ganglion is going to fire to the ipsilateral thalamus, and there's a loop here that it's going to fire right back to the frontal lobe. All right, and then what this is going to do, this is going to cause the frontal lobe to fire down contralaterally, okay, and give the muscle contraction and movement the appropriate amount of amplitude, if it will. So when I tell somebody to take their finger and put it on their nose, and then I'm going to put my finger in space, what should happen is we go like this, okay, and we move it in different directions, and we should see something like this. So if somebody has this frontal lobe, like this lady had, her direct pathway was damaged, all right, and it was more of her left frontal lobe. So when we're doing this, she's like, so see, her cerebellum and her direct pathway is off, okay? And we go into a different area, and she's really, really slow, and yet her coordination, she can't really go right to the finger. This side right here, boom, okay? So here, and then here, it's like, she's really having to focus. Her fatigue is off. So when somebody tells you that they're having fatigue issues, okay, like focus, attention, and concentration, you know that's a frontal lobe dysfunction. Anxiety, depression, frontal lobe function. She's fatigued throughout her whole body. Like if after she does a few things, we did the right eye on her, and after 4 minutes of doing that actual test, she was just almost exhausted. She was almost exhausted through the exam, by the way. So now what happens is your cerebellum is presynaptic to the frontal lobe. So what's going to happen here is your cerebellum actually fires to the frontal lobe. Let me back up just a second. I kind of skipped a couple of steps here, and I do apologize about that. Okay. So this cerebellum, what it's going to do, it is going to fire to the contralateral red nucleus. All right. And then from the red nucleus, it's going to fire to the thalamus, and from the thalamus, it's going to fire to the frontal lobe. So now, when this is important is because, see, this basal ganglion and cerebellum, they fire back to the frontal lobe through the same nucleus, which is awesome for us because, see, we can rehab the cerebellum, we can rehab the basal ganglion, we can excite the frontal lobe, and we're stimulating all of those neurological pathways. So the key takeaway here, the key concept here is my right cerebellum, which is going to control accuracy, balance, coordination, and eye movements with my right arm and right foot. All of that fires into the ipsilateral cerebellum and contralateral brain, parietal lobe and frontal lobe. All right. Now, said another way, sensory input. This cerebellar function, eye movement, accuracy, balance, and coordination with this left extremity, hand, feet, and eyes, this is going to fire to the contralateral brain. So one of the tests that we can do as well to test this basal ganglion, there's a lot of things we can do. Like, again, when I asked this lady to put her finger on her nose, and this side right here, she's just really, really, really slow, okay, and touching her nose. Here was fine. Here again, all right, and she also has hypotonia, which she's like, you know, she's talking coherently, but it's like she's talking like this, and she can barely get the words out of her mouth, almost like she's whispering, okay? That's another type of a direct pathway in the basal ganglion. So she says that she's having problems getting the words out. She can actually understand what people are saying, but she's having a problem not coordinating, but actually getting the right words out. So see here, she's screaming left brain problem. Left Wernicke's area means that, we're getting the sensory input in and we're understanding the words someone's saying, but to get it from the Wernicke's into Broca's area, she's having a difficult time doing that. So she starts telling me this, and I'm like, okay, sounds like a left brain problem. And then she's like, I get cramps on the right side of my leg, okay? Could be frontal lobe, could be basal ganglion, and she's like, when I start to do things, I start to get these tremors. All right, so and this could be, that could be a lot of things. That could be basal ganglion, that could be a cerebellum. Usually basal ganglion is going to be resting tremors, but when we start to move, this can be more indirect pathway. That's see, we're moving in a way we're don't want to move. We're getting cramps, okay, and when she's getting this in her lower extremities and she's doing this, all right, she can do this and no problem. No problem there, but she starts doing this and she starts going almost like into a seizure disorder, okay? Could be an indirect pathway basal ganglion on the left side, could be a cerebellar problem on this ipsilateral side. So we're not gonna rule out any one of those because we know that she has a right cerebellar problem, left frontal lobe, and a left basal ganglion. So see, if we start to look at these people this way, then we can start addressing, okay, how do we test the frontal lobe? And then what do we do about this? I mean, because this woman has already been to the medical neurologist and then MRIs, all the imaging that can be done, nothing is wrong with this woman. She should be, quote, normal, okay? And that kind of drives me up the wall when I hear these kind of things. And this lady is 60 years old, and she's walking in the clinic with a walker, and she barely can function as a human being. But everything's normal according to her imaging, okay? So the way, when we get back to this next module, I think it's 3, we're going to go over how do we actually treat this through using the cerebellum, basal ganglion, eye movements. And so one of the things that's important when we're dealing with frontal lobe function as well is if I can, all right. So one of the ways we can test the frontal lobe as well is when we look at the frontal lobe, okay? The frontal lobe has to do with, in area 8, we have what is called the frontal eye field. Okay, let me check my time here real quick, make sure I'm doing okay on the time. And so we're going to have to wrap this up pretty quickly. So this right side, this right frontal eye field, all right, if I'm fixated here and I saccade to the right, I said left frontal eye field. I don't know what I said before, please forgive me, but left frontal eye field. All right, so we're fixated on this finger and we move this finger, and this eye movement is called a saccade. All right, so right here we're fixating again, boom, all right. All right, fixation is a frontal eye field, frontal lobe function. If your frontal lobe is bad, instead of saying fixate your light, you can't stay fixated on an object. So that would be one of the rehabs as well. But we're going to saccade to the right, boom. Our left frontal eye field actually saccades the eye to the right, okay? So we want to look at that and see if there's a latency, is the velocity there, and the termination. So if we have a frontal eye field function and I move this finger, and I move it, and then see like the latency here, like I can't activate, like I'm too slow in moving it, that would be potentially a frontal lobe on the left side. And if I fixate here and I saccade to the left, this is a right frontal eye field. One of the biggest components here when patients come in, also with this prefrontal cortex, this has to do with cognition. And I can't say this enough, it's focus, attention, concentration, and executive function, or FACE, okay? So you start to ask patients, are you losing focus, attention, concentration? Yes, yes, and yes. This is the frontal lobe function, okay? And this focus, attention, and concentration has a lot to do, again, with our oxygen level, glucose, our stimulation, and decrease inflammation. Because when we don't get adequate oxygen or glucose, then we can't activate the mitochondria, and then see our nuclear power plant's not working, and we start to lose that energy. We start to fatigue physically, and we start to fatigue from a cognitive standpoint. So focus, attention, and concentration. All right. And remember, when we lose our brain function up here, we have what is called the hand or the central autonomic network. And the central autonomic network sends through the vagus nerve, which I write about in my second book, and that controls stomach acid, gut motility, the permeability of your gut function to keep you from having a leaky gut. It also controls your, if I didn't say gut motility, your liver making bile, your gallbladder secreting bile, your pancreas to release enzymes to actually break down carbohydrates and fats. So again, it's not just I have a frontal lobe function, okay? It's not just I'm not moving correctly in the world. It's not just I have focus, attention, and concentration and executive dysfunction. And I'm going to leave it on this part here. All right, nothing with a chronic pain patient or chronic, let's say, focus, attention, and concentration or early onset dementia, or somebody comes in with chronic knee pain or peripheral neuropathy. None of these things happen in isolation, and I can't say that enough, and please put an exclamation point on that. None of these things happen in isolation. Now, you may not be able to explain it because you don't understand the neurology behind it, but again, whenever you understand the neurology behind what's going on, okay, again, like I'm having this problem finding my nose, okay, balance problems, firing to the left brain, focus, attention, and concentration. Do you left brain, do you have a problem understanding what somebody says? Do you have a problem getting the words out of your mouth? Okay, right brain is going to be more what's happened to your personality. What about your social skills, your social graces? What about abstract thinking? Have you lost that? Can you visualize walking through your home? Okay, see, these are all right brain issues, frontal lobe. So again, thank you very much. I hope you learned something here today in this little 20-minute video. At the next video, we're actually going to be going over how do we actually rehab the frontal lobe. I'm Dr. Andy Barlow with the Barlow Brain and Body Institute. Thank you very much.